All right, we are live. Good afternoon, namaste, and happy or not, but World Diabetes Day it is. It was yesterday, and warm welcome to all of you, to our entire panel. My name is Shayan Bhattacharya, and we are from Apollo Spectra Hospitals Group. It's a pleasure for us to host and moderate today's World Diabetes Day webinar and panel discussion, where we try to bring you all the latest strategies, details, and management of diabetes in 2025. And for people who are not diabetic yet, thankfully, how to sort of go about it and stay that way. So we have an outstanding panel with us to begin with. We have outstanding panel of experts from across the West region, from Mumbai, from Pune, representing internal medicine, representing general practice, endocrinology, general surgery, and urology as well. So one of the things that we try to do today is bring a very cohesive environment wherein we have all the people who day in and day out see 500,000 patients pertaining to diabetes in their practice regularly, as well as bring super specialists from the field of urology, from the field of prostate, from the field of general oncosurgery and all, and as well as opthal, to get a buy-in as to what are the kind of management therapies that they intend to have when a diabetes patient walks in. So we have super specialists as well as general medicines, and I'm excited that it's gonna be a wonderful panel today. Uh, right. So the fact that each of them brings a unique perspective to diabetes care, from prevention and diagnosis to management and long-term health, is what we are looking forward to today. Let me first, I think, set the context by saying that India continues to be at the epicenter of global diabetes crisis, with over 100 million adults currently living with the condition. And more than anything, what's worrying is not just the sheer numbers, but how the disease is constantly affecting the younger individuals. The younger individuals, and juvenile, at pre-diabetes is at its peak now, with almost everybody at borderline. आप किसी को भी पूछो, everybody says that I am at borderline. I'm at borderline. I'm like, how old are you? I'm just 20, but I'm borderline. That's a worrying thing. That's a very worrying and a very complex sort of condition to deal with in a ever increasing population in India. And even for that matter, and because my panel today is from West, even for that matter, if we look at the closer details at Maharashtra, I have a few details here with me. The picture is very striking in Maharashtra. Studies have shown that both Mumbai and Pune have among the highest urban diabetes prevalence rates in the country. And with an increasing trend of comorbidities like hypertension, obesity, neuropathy disorders, I'm sure most of you agree, the kind of patients that you see every day. These overlapping conditions only make it very, complex and critical to deal. So, like in Apollo, we always say that early intervention is the best form of intervention. It's the best form of prevention. So it's always good to know what you're dealing with, right? And exactly in that note, we have our theme for World Diabetes Day this year, which is empowering access to diabetes care, right? Because if you have access, if you have knowledge, if you have information, I think you can fight anything. Um, so let me just conclude this opening note by saying that it is not going to be a discussion. It is going to be a shared effort towards creating healthier communities and empowering individuals to take charge of their well-being. And like I said, we have a delightful panel. Let me first introduce Dr. Kavita Rane. Ma'am, thank you for joining us today. Dr. Kavita is an accomplished diabetologist with over 2 decades of experience in internal medicine and diabetology, and specializing in the management of diabetes, hypertension, other metabolic and lifestyle disorders. And known for her diagnostic precision and compassionate care, Dr. Rane has been instrumental in promoting preventive health and holistic patient well-being. Thank you, ma'am. We move over to Dr. Tushar Rane. Dr. Tushar is a senior consultant in internal medicine with an extensive and rich experience in chronic disease management, right? Particularly diabetes, hypertension, and infectious diseases. He is recognized for his evidence based approach, his clinical excellence, and commitment to patient education. Thank you, Doctor, for joining us. Dr. Chaya, ma'am, one of the senior most in our panel today. Dr. Chaya, we are very privileged to have you today with us. She is from Apollo Spectra, Tardeo, Mumbai, and she is somebody who has committed herself to serving the community for a massive 41 plus years as an internal medicine specialist. Her experience, as well as her insightful understanding of challenging cases over the years, are truly invaluable for our discussion today. So, thank you, Dr. Baja, for joining us. Uh, Moving to our ophthalmologist in the panel, Dr. Nusrat Bukhari. Thank you, ma'am, to take time from your busy schedule and join us. Dr. Nusrat is our leading ophthalmologist in Apollo Spectra, Mumbai. She has more than 15 years of experience in her specialization, and we are really happy to have you as a part of the panel, especially because I am very keen and I'm looking forward to understanding the nuances of, ophthal care in diabetes, because that's, one of the most key things that affects in uncontrolled diabetes, right? So looking forward to your inputs. And then we have our super specialists, Dr. Sanjay Dhangar, and we have Dr. Kiran Kumar Jadhav. A little about Dr. Dhangar. He is a leading urologist and kidney specialist with a vast experience in endourology, andrology, uro-oncology. A respected academician and clinician, he has contributed significantly to advanced urological care in Western India. Dr. Dhangar's work emphasizes the impact of diabetes on renal and neurological health, with a focus on precision diagnosis and advanced surgical interventions. Thank you, Dr. Sanjay, for joining us. And last but not the least, Dr. Kiran Kumar Jadhav is a highly regarded general and oncosurgeon, specializing in minimally invasive and cancer surgeries. His expertise spans gastrointestinal, breast, soft tissue oncology, and he is known for his meticulous surgical skills and integrating multidisciplinary care to optimize outcomes for patients with diabetes and cancer related surgical needs. Thank you so much, sir, for doing this, and thank you for joining us today. So, without further ado, and as you all have now known, that a fantastic lineup of discussion is going to happen, let us start, right? And let us start with Dr. Kavita Rani. So, Dr. Kavita, my first question, which I have to, I think, अगर हुआ जाता है questions का, तो the first has to be gestational diabetes, because everything starts with that, right? Gestational diabetes is fairly common these days, right? क्या जिनको जेस्टेशनल डायबिटीज होता है, प्रेगनेंसी के दौरान डायबिटीज होता है, क्या ये तय है कि उनके बच्चों को भी डायबिटीज होगा आगे जाके? I think it's a very common question that everybody asks, right? What is your take on that?
This is an extremely important question. So, San, what happens is during gestational diabetes, there's a huge load of hormones on that woman who's undergoing pregnancy. So, riding estrogen is like riding a horse. You have to learn. So, all females have this hormone called estrogen. So, when the estrogen and progesterone increase in a female's body, so if she is pre-diabetic, she's going to get pushed to diabetes. And this sugar needs to be controlled right through all of her pregnancy. And if those sugars are not controlled and kept in check, a very tight control, because that affects the infant, the neonate, the baby inside her. And which means that aage jaake, if she does not control her sugars during pregnancy, that baby is at 50% chance, which means genetics plays such an important role. The baby is at 50% chance of getting diabetes for sure aage jaake. So diet, exercise play a very important role even in a pregnant lady's pregnancy, right through the first 3 trimesters are very important for her.
No, I think yeah, definitely, because if I think during that critical time, if somebody can't take care of themselves in a proper manner, आगे जाके ना कि उनको, but even the child is at fear. So
Yes.
I think a very important message for all of you. And in fact, on that note, let me quickly go over to Dr. Chaya डॉक्टर छाया, हम सभी ने कल चिल्ड्रंस डे मनाया. We had a happy children's day yesterday.
बरोबर आहे.
Unfortunately, a lot of cases of pediatric diabetes, is being recorded nowadays. So, what is your take on that? And is childhood diabetes reversible? That's my question to you.
See, there are two types of diabetes. One is type 1, another is type 2. So, in type 1, it is the diabetes is since childhood. So, for that, we have to take injections, take diet control, walking, and all. But in even in younger people, we are getting diabetes like there are people at the age of 20, 25 also they are developing diabetes, which is called MODI type 1 and type 2 diabetes. So in these are the hereditary diabetes and because sometimes both the parents are diabetic so that the children are getting diabetes in the early age. So usually parents should have knowledge of this and should check their children whether they are having type 1 and or type 2 diabetes, and accordingly they have to consult a diabetologist, and then they have to go ahead with the diet control, walking, medicines, injections, depending upon the type of diabetes the child is having.
ये आपने बड़ा सही चीज बोला कि फैमिली एंड पेरेंट्स का इंटरवेंशन एंड हेल्पिंग मैनेज द होल थिंग थ्रू आउट their journey is very crucial. I'm going to put it together. In fact, on that note, my next question to Dr. Tushar is, Dr. Tushar, what can parents of juvenile diabetes do to help their helping individuals adopt a sustainable lifestyle change for long-term health? जैसे कि हमने सुना अभी डॉक्टर छाया से.
So, in the children, the most important thing is the children have to have the a proper knowledge about what disease that they are having. So, when we say that children, usually we mention about type 1 diabetes. So,
Yeah.
in type 1 diabetes, they should be counseled properly about how do they take care about their blood sugar levels, then about the diet and exercise. So, in diet, what they need to do is they have to teach their children about calorie counting, what diet they will be having, how to count the amount of calories that they are consuming when they are taking insulin injections, how to calculate the uh, units of insulin, how to inject themselves by themselves, and not to pamper them, rather guide them in helping them be uh, independent when treating themselves for diabetes.
नहीं,
So
ये
these are the basic
definitely,
things
हाँ,
that
very
we
pertinent.
need to do for children. They basically need to be counseled. If at all they require a counselor, they have to be taken to a counselor, and they have to be taught. They have to have proper knowledge of what the disease they are dealing with.
Right. So I think a key message from your point is awareness, awareness, and awareness. I think one has to be aware to fight it, one has to be counseled to fight it, and one has to be very, very regularly cautious about what is happening in their body. So I
True.
think this, continuous glucose monitors, the CGMs, and a lot of devices are there today, which earlier was not there. Which helps a lot in monitoring the situation, and then of course taking good care of it, right? Which brings me to my
That's
next
right.
sort of discussion, and I'll go over to the super specialists in a while. But let me sort of first start by the very introductory, basic level of awareness questions that a lot of people have in mind usually. Dr. Kavita, again to you. Uh, Acha, so and I also had this question, like in my mind, कि बहुत सारे लोग जो है, they are active, they play sports, they are engaged in some sort of an activity, they have a good clean eating style, lifestyle, food habit, they have a great lifestyle, उसके बावजूद क्यों डायबिटीज होता है उनको? What do you have to say about that?
That's a very good question, Sam. See, we know that 50% is because of genetics. So, अगर आपके माँ बाप को है, anyone in your bloodline has diabetes, you're going to have diabetes. But that doesn't necessarily mean that you're not supposed to take care of your lifestyle. So, lifestyle modification is very important. The other thing that happens is age. With age, some people develop diabetes क्योंकि जैसे स्ट्रेस बढ़ता है, स्ट्रेस लेवल्स बढ़ते हैं, आपको पता है लोग कॉर्पोरेट में काम करते हैं 10 10 12 घंटे या 24 घंटे भी काम कर लेते हैं because the corporate needs it, but that's not the right thing. So stress is one of the factors. Plus in women, hormonal imbalance is the other factor. Women, especially women beyond 40, need to take care of their health because there's going to be premenopausal or menopausal or whatever the other hormonal issues they have. PCO is the other issue that most women have. It is statistics is 7 in 10 women already have PCO or mild PCO. So those are the hormonal imbalances. Then there is poor sleep. You're trying to sleep, but your phone comes in the way. People don't leave their screens and they don't want to keep their screens away. And the blue light in your screens is affecting your sleep majorly. You need to understand you have to put filters on your phone through the day. So your eyes need rest. So that increases the cortisol levels in your system and that can cause diabetes. Also, there is something called hidden visceral fat. Okay. So when people, so there are certain specific tests that come for getting to know how much your visceral fat is, certain DEXA analysis or like a body composition analysis. These things tell you how much your visceral fat is. There are two types of fats, external, which you can see, and internal, which is around your organs, which you cannot see, which is the most dangerous kind of fat. So this causes insulin resistance. And if you've seen certain people have fat around their midsections, the stomach, and that is very difficult to go away. That is like it is a very dangerous kind of fat as well. That tells you that that fat is going to cause insulin resistance, which might lead to diabetes and heart disease. So
Right.
this is what is most important and what you asked me.
No, I perfectly explained. And on that hidden visceral fat thing, which I've made a note of, I am going to come to Dr. Kiran in a bit about that and want to understand more from his point of view. But I want to sort of now go over to the ophthalmic section a little bit, the eyes, and how does a diabetes person represent with eye conditions, right? So, Dr. Nusrat, over to you. Many patients believe vision loss in diabetes is inevitable. मतलब होना ही है. So, how true is this? How can it be managed? And how much of diabetic eye disease is actually preventable with timely treatment? मतलब डायबिटीज है तो आंख जाएगा ही जाएगा, इसका I don't think there is any this thing, right? What do you have to say? You're on mute, ma'am. You're on mute.
Okay,
Yeah.
so it's actually a very big myth that people have created around them. I would say those who don't want to work hard, okay, and those who want to avoid doctor visits may be creating that myth. The basic fact is that diabetic retinopathy उनके अर्ली स्टेजेस में काफ़ी एसिम्टोमेटिक रहती है. जो मेजर सिम्टम्स एक पेशेंट एक्सपीरियंस करेगा, लाइक loss in vision, blur vision, floaters, sudden transient vision drops and rises. All these things are seen when the patient already has a retinopathy which has crossed from mild and become moderate to severe. So, and what I want to say here is that if you have a regular checkup from the time you have been detected diabetes, and if your sugar levels are under control, if your creatinine in your kidney is fine, working fine, your creat levels are under control, the chances of you developing, the patient developing a diabetic retinopathy really, really falls down. If you are maintaining the sugar levels well, if you are exercising, if you are having your regular eye checkups, because as I said, the initial stages which are completely curable are the stages which are going to be painless, asymptomatic. Patient will never experience even dry eyes. Okay, so it is, the retina is itself not the part of the eye that will reciprocate to any pain or anything. It will silently keep getting worsened day by day, night after night, with the HbA1c rising, with the creatinine rising. Diabetic retinopathy at two folds or three folds starts increasing in such patients. So first very thing that I would pay a lot of emphasis on would be do regular checkups. If you are a type 1 diabetic, if you are a juvenile, if you have a family history, so type 1 and juvenile, they have to minimally go at least 6 months to 1 year, once a year at least, show their doctor, have a proper fundus evaluation, not just the anterior part of the eye that, okay, you got your number checked by a spectacle person. Actually, this is one more myth that I would like to throw some light on. In India, we feel ki chashme wale ko aankh dikha di, to, I'm sorted and I'm clinically very healthy. My eyes are perfect. Mujhe sab dikh raha hai, matlab I'm good. No, that's not the thing. In diabetes, in diseases like glaucoma, all these are your silent killers of vision. They are not like cataract, where your vision will become blurred and you will experience some cloudy vision, you will experience some daylight discomfort or evening no. In these diseases, everything happens silently back at the end of the retina. The neural tissue silently gets destroyed day by day. So only regular fundus evaluation, regular retinal evaluation, eye evaluation will help you keep an eye on it and help the doctor to catch if there is any early changes in your retina, in your lens of diabetes. So
Perfect.
my very big request to all the diabetics, all the pre-diabetics, especially the type 1, the juvenile, is regular strict eye examinations, thorough eye examinations by an ophthalmologist, not by an optometrist or random glass person.
I think it couldn't have been explained better. And the major thing, the takeaway for me, I think, for everybody watching this, is going to be regular health checkups, regular eye checkups, to ensure that you don't knock the door when it's done and you can't do
It's done,
anything
yeah.
about, right?
Yeah. Yeah.
So great point, ma'am. Right. Thank you. Dr. Sanjay, moving to a little more heavier topics, because as we know, diabetes can cause a lot of comorbidities and a lot of issues, and prostate and urinary tracts and sexual functions, andrology, and kidney are no different than being at the risk. So my next question to you is: what are the possible long-term health risks to to other organs, for somebody with diabetes, including the kidneys and the urinary tract? Could you explain how typically diabetes impacts anybody's urological health, and what are the early warning signs that somebody should look for? Over to you.
Yes, definitely. Diabetes has impact on the urological health. As Madam told just now, that before affecting retina, diabetes goes through the kidney. So it means that whenever the creatinine level is rising, it is involving one or the other organ. So uh, the impact on urological health mainly because of the nerve damage and involvement of the blood vessels due to the deranged sugars or because of insulin resistance or high insulin levels. Mainly, there are more chances of urinary tract infections, which is the most common thing, followed by kidney damage, bladder dysfunction, and sexual dysfunction. Among these, how patient can recognize is patient have routine symptoms of urinary tract infection, like patient may have to pass urine very frequently, they may feel burning or pain while passing urine, they may have cloudy urine or they may have a foul smelling urine. Similarly, they may have difficulty in starting the urine or stopping the urine. They may feel strong urge to pass urine. So these are all the signs and symptoms that patient should recognize. Sometimes they may have pain in the back also, either because of the infection in the kidney or because of the stone associated due to increased urinary tract infection.
Right, right. And in fact, on that note, I have just two follow-up questions on that. You mentioned creatinine level at the beginning. So, what is the ideal creatinine level, for a person to maintain?
Okay, ideal creatinine level is 1, though it varies from lab to lab. Some, because in some lab it is less than 1.2, it is less, somewhere it is less than 1.4, but ideally it should not go beyond 1.
Okay.
Even if it goes beyond 1, then it should raise eyes and ears of the dealing person that it is going beyond the normal level, and patient should check or should see the physician or the surgeon concerned in his or her health care.
So, I think thank you so much for clarifying that for us.
Thank you.
So keep messaging so far that has been sort of set out by the panelists, in the webinar. Number one, have regular health checkups, regular eye checkups, in order to ensure that you are at the peak of your health. You know about what is going on inside your system. Your creatinine levels and all should not be beyond 1, right? In order for you to evaluate that you are functioning perfectly. And if there is any issue, uh, in that case, there are the doctors who are always at the helm of things. So, please don't hesitate to reach out. Right. My next question would have been to Dr. Kiran, but I think he's having some difficulty, a technical glitch. So we will go on to him once he comes back. Meanwhile, we also mentioned HbA1c levels. So, Dr. Tushar, if you can just, what is the ideal HbA1c level today? Because there are a little bit,
Right.
I think, थोड़ा सा understanding a problem है, मतलब, with the literature in Indian context and in American context. So, if you can clarify on that.
See, from the Indian point of view, let's
From the
not
Indian
go
point
to
of view.
America.
Yeah.
So, from the Indian point of view, the ideal HbA1c level has to be less than or equal to 6. If at all our HbA1c is going beyond 6.5, so 6 and 6.5 will be, you can say the patient would be in a pre-diabetic state. So again, let's compare HbA1c with fasting blood sugar and its normal values. So when do we say that the patient is having diabetes? So there are some diagnostic criteria for diabetes. In fasting blood sugar of 70 to 100 is a normal blood sugar level. Fasting blood sugar from 100 to approximately 125, 126, it is called as pre-diabetes. And anything beyond 126, we call that the patient is having diabetes. Similarly, with HbA1c, it is the same thing. 6, less than 6, normal. 6 to 6.5, it is pre-diabetes. And 6.5 beyond, we call it diabetes, and we need to tackle the situation accordingly with diet control, exercise, as well as medical management if at all required. So this is all about HbA1c and fasting blood sugar. Postprandial blood sugar comes in line while treating the patients with diabetes. Postprandial blood sugar does not come into the diagnostic criteria or in the diagnosis of diabetes. So when we have to diagnose a patient for diabetes, it's all about fasting blood sugar and HbA1c level. So that needs
Perfect.
to
I
be
think.
seen first. Yeah.
Right. So that
And
clears the air for a lot of people because
true.
क्या होता है ना, a lot of people have this thing कि नहीं नहीं मैं तो pre diabetic के range में हूँ. But then what's your thing? It's 6.2. But then according to some journal where I read, 6.2 is. But
Yes.
I think one has to understand that in India you have to refer to the Indian context. So this is very important to get the clarification. Thank you, Dr. Tushar. We go to Dr. Kiran. Thank you, sir, for joining back. I think there was some technical glitch at your end. So if you can just unmute yourself. Yeah.
Yes.
So, Doctor, my open-ended question to you, and as we have you today in our session, an esteemed general surgeon. What is the role of a general surgeon in managing diabetic foot ulcer patients, and what are the newer modalities in diabetic foot ulcer care? If you can please
So
explain.
now, up till now, we have got the idea. Up till now, we have got the idea what is the diabetes and how the things. So whenever we are going with these things, most of the patient known diabetes. So for the long period, about 10, 12, 15 years. So 40% of the diabetic patient, although they have controlled diabetes or uncontrolled, they go to the diabetic foot ulcer in their once in their lifetime. So whenever we are talking about the diabetic foot ulcer, so it is a multidisciplinary disease where from the different
Sorry.
surgeon. When we are talking about the diabetic foot ulcer, so the treatment management, we general surgeon we consider it as a time. So that is include tissue, I for infection, M for moisture, and E for the equipment which are utilized for the things. So what that work out? So tissue means what? Because of the decreased vascularity in the peripheral area of the foot, either it is because of the very high sugar level or there is a loss of neurovascular sensitivity to that area. So it might have the trauma to that patient because the patient might not know the sensitivity is lost. So there a trauma will not recognize and it might get infected. Sometime it get infected, or the tissue might be dried. So because of that, there will be the ulcer formation. So when we are talking about the M and E, so that time what happened, the wound is there, so the general surgeon's work is started in picture. So we mostly work out debridement of that tissue, or might require to release the all dead tissue from that area, or we might require to release the remove amputation doing for the small toes or fingers like that. So that is the important thing. And the third most part is the management. So when we are talking about the management, so basically up till now what we do the debridement. Regular debridement is more important in case of diabetic foot ulcer as compared to the normal wound. So where the healing process is very fast. While in case of the diabetes, because of either it is a very high sugar, because of decreased vascularity in that area, because of the narrowing of the vessels, and third is loss of sensation and decreased immunity of that patient because of this high blood sugar levels. So that wound is not get cleared, and most of the time there will be the bad tissue. So every time we have to go for the debridement and maintaining that area more and more healthy. Second thing, whenever we are talking about the wound management, so moisture is the most important thing about the diabetic foot ulcer management. So if it is very moist, so because of that high exudate also the tissue will not grow in that area. So because what we require whenever we are talking about the wound healing, so it means angiogenesis means there has to be new vessels has to come in that area, new cells has to develop, and growth of that cells will cause granulation and which will heal that wound. So whenever there is a very high exudate, so what will happen that the cells will become moist and it will get swollen and it will not heal properly. Second, and the contrary, if it is the wound is very dry, so what will happen that the new angiogenesis cells which will become a dried because of the environmental thing and it will not heal properly. So for that purpose we have covered up to the M. So now E, the equipment. So now newer modalities, what newer modalities are come in picture. So there are three different way. What are the we are covering that time. So antiseptic in a local area, I'm talking about just local area. So antiseptic in local area. Second thing, we have to maintain the moisture in that area. Third thing, we have to use some chemicals or some material which will improve the neoangiogenesis in that area. So according to that, we have to go for the betadine or some solutions, or you can go for the radicals. So silver nanoparticles, so hydrochloric acids. So this will improve that cell irritation and increases the granulation in that area. Sometimes we can use growth factors and genetical factors also come in picture. So the thing, these are the for the wound management, and the final management required is you have to grow that granulation. Second thing, we have to cover that wound. So now we can cover that wound either going by the grafting or flap. Even now in a new modalities, we are getting the artificial grafts. So that graft can be help to improve the wound healing. So these are the newer modalities. Along with that, when we are talking about the equipments, so we have got very nice system available in market, that is a negative pressure, the VAC machine. So negative pressure will, it is a process technique where we can use 110 to 120 pressure to suck out that excessive exudate from that wound area. So that is negative pressure, means we are using a foam of 400 to 600 micron holes, and we are keeping that hole, we making that area pressure with negative pressure. So it is completely covered and it is connected to the instrument which will suck that exudate, either it is a continuous mode or in a intermittent mode. So because of that, it will not completely dry out the wound, but it will
Right.
maintain the moisture of that wound, and that will help to increase the granulation in that area. Also, some techniques like instrumental debridement. Second thing, we can use the laser therapy, and some plants and some materials which are algae or something like may be used to increase the granulation. So these are the very new modalities. Although it is costly by price, but it is not costly for the patient care. Why I am saying, because when you are going for the natural thing, so regular dressing, so every day you have to use the dressing, there is a utilization of that materials daily, even though there is cost is less. But when you are going for the newer modalities, our dressing time is also decreased, either twice in a week or thrice in a week, as per the need of the wound. So when you are comparing that amount as a twice in a day, twice in a week, so it will comparatively equivalent. And the second thing, the social behavior of the patient is also changed, because the patient or his relative, there is no need to every time you have to think, okay, no, tomorrow, today doctor has called at 6 o'clock and we have to go daily for the dressing. So you can organize once or twice a dressing, so it will be more emotionally helpful for the patient also.
No, so I think, yeah, we got the picture. You know, there is management possible at every level. It's just that one has to be aware and one has to timely check the things in order to understand and not go till it is beyond control. Right. So thank you for the elaborate
Yes.
explanation. No wonder it came from an eminent professor. So, I think that really covered it. Dr. Chaya, over to you, ma'am. Very pertinent question for a lot of people who are diabetic, and when they are planning travel, when they are planning trips and all, तो बहुत सारे लोगों को ये मतलब दिमाग में आता है कि what should they carry, what are the things that they should carry being a diabetic. So that is one thing that I want to know from you. And second thing is, agar by chance traveling or not, but by chance agar if the sugar levels drop a lot, then they go into a some people go into a very emergency phase. Some people manageable, but some people literally fall down and they go to a very emergency
Hypoglycemia.
condition.
Yeah.
Yes. So in that case, how do you manage hypoglycemia, and what are the sort of techniques that today vis-a-vis 10 years back, hypoglycemia management का जो भी अभी latest आया है tips, so how do you sort of want to go about it?
Yeah, actually, when the patient is traveling, so he has to make lots of planning before traveling because he's diabetic. He has to carry with him many things like fruit juices, water, glucose tablet, glucometer, and if he's traveling with the relatives, so relatives should be taught how to deal about the patient's sugar levels, how to check sugar level, how to treat the hypoglycemia. Because while traveling, many times they are drinking less water, so there are chances of dehydration. Patient going into hypoglycemia is very high, and regularly patient has to every 3 to 4 hours patient has to drink water around 8 to 10 glasses of water he should take while traveling. Then he should keep all snacks and everything ready with him, so time to time he can eat it and every 3 to 4 hours he should check his glucose levels on glucometer and see whether his glucose are on the normal range or he's going towards the hypoglycemia. And he should carry glucose tablets or sweets or chocolates with him, so whenever his sugar levels are going down he can immediately take that glucose tablet or chocolates or anything. And such patients should be have a relative also who knows well about all the diabetes condition and who can help the patient who are traveling with him. So I think if patient is having is on continuous glucose monitoring, now we have come with recent advances of continuous glucose monitoring, that patch
CGM
is there.
machines. Yes.
Yeah. तो वो अगर if they are having that, so it becomes very easy for patient to monitor his glucose level, whether it is maintaining his glucose level, or it is going down or it is going high. So accordingly, this patient also has to be educated how to deal about his diabetes when he's traveling.
Yes, Dr. Tushar, please.
Yeah, one more thing that I would like to add here is these patients have to regularly have a follow up with their consultant, so that the consultant regularly checks up on their blood sugar levels and accordingly adjusts the dosage of the medicines or insulin that they are taking, so that they can prevent hypoglycemia complications that might occur.
Right. And in case of any long duration travel, abroad travel or something, it is
True,
better to keep your doctor informed about it so that there is
true.
necessary tips and management strategies that the doctor can keep guiding you on. Great.
Sure.
So
Yeah.
thank you, Dr. Chaya and Dr. Tushar for covering it nicely. Yeah. Uh, Dr. Chaya mentioned a lot of food and things that one can carry in order for them not to have any attacks or anything. And that brings me to my next question to Dr. Kavita. So, Dr. Kavita, there are a lot of things in the market, okay, which are substitutes for sugar. Jaggery is a good substitute for sugar. Stevia, monk fruit, so many things are there. What is your take on that? Is honey, jaggery, stevia, these are good? Is monk fruit good? And what do you recommend for somebody who is trying to get off sugar?
So, Sen, honey and jaggery are equal to sugar. They're the same. So, whether you take sugar or honey or jaggery, your sugar is going to spike. So, it is up to you what you want to replace. But what you said about stevia, that is 0 calorie. Yes, that is very safe for diabetic patient and will not give you a glucose spike. Also, monk fruit is very good. Monk fruit powder comes, so then that also is 0 calorie, and that is very good for a patient to try as an alternative.
So I
Apart
think
from
for a
that,
lot of
yeah,
yeah.
apart from that, they could keep crackers or some. There are sugar tablets also that come. You can carry them along, and it is important, necessary that all these patients who travel also have their needles in case they are on insulin, because patients on insulin go into hypoglycemia very severely, and at that minute there has to be something in their bag. Also, they have these bracelets that they can carry along, which tell and identify that they are diabetic, so people around them, in case of an emergency, can help them.
Right, I think that clears the air. A lot of people who are in confusion, that there is a good alternative of sugar, which is honey, jaggery, and all that, and living under the rock by thinking that ये खाने से तो ठीक हो जाएगा. I'm not consuming sugar, so I'm fine.
Yeah.
So I think this is a clear message to all of them that if you are ending up having jaggery or honey, it is almost equivalent to having sugar for a diabetic person. So better
If
stay
you
away
don't
from
believe
that.
me, you can check on a continuous glucose monitor yourself. You put that sensor on, you eat sugar and then check your spike, and then you eat jaggery and honey and then check your spike. If you all don't believe it, go ahead and do that.
So I think that's a clear call to action for a lot of people. Why don't you try and then send in comments.
Yeah, yeah.
What is your results? Right.
Yeah.
Dr. Sanjay, next question to you. We have seen a lot of people in older age groups, especially having prostate issues, because of diabetes or otherwise. But um, first of all, is there any connection between diabetes and prostate issues? And if it is there, then what to what extent can prostate conditions be sort of alarmingly rise due to diabetes? What's your take on that? You're on mute, sir. You're on mute, please. Yeah.
Sorry.
Yeah.
Yes, there is a connection between diabetes and prostatic health in the form that uncontrolled sugar leads to increased risk and severity of the enlargement of the prostate. So what happens is because of the hyperinsulinemia and insulin resistance, uh, this, these actually act as a trophic factor, like they act as a growth stimulating factor that leads to increased growth of the prostatic cells. So this will lead to enlargement in the size of the prostate. Apart from that, uh, because of neuropathy associated with uncontrolled sugar, bladder problems can occur simultaneously with the prostate. So two problems together. So in this way, if you see there is a direct impact of diabetes on prostatic health. Then apart from this, uh, this I explained was the risk of benign enlargement of the prostate. But if you see about prostatic cancer, there is a bit confusion that it increases or it does not increase the risk. But overall, the risk is increased because normally what we do to check cancer of the prostate is we do uh, serum PSA. Serum PSA is reduced in patients of diabetes because of the inflammatory issues with the prostate. So it is not easily diagnosed. But if diagnosed, the severity is very high as compared to a normal person. So overall, the there is a direct correlation between diabetes and the prostatic health and increased risk of benign enlargement of the prostate as well as increased risk of the carcinoma of the prostate. So all patients have to take care of their urological health. So whenever they experience any urinary symptom, they should report to their urologist or their concerned physician so that they can be diagnosed on time.
Right. Thank you so much for your inputs, Dr. Sanjay. Um, in fact, apart from prostate, I think one of the most common pool of patients that show up on the OPD, are cataract patients. Right. Dr. Nusrat can agree. So there are so many elderly diabetics who tend to undergo cataract procedures in their years, in their later years. Right. What are the additional precautions that they should take before and after the surgery? So imagine that somebody has to go for a cataract surgery. So, how should you guide them before and after?
A patient once diagnosed with cataract, usually always from the time the disease has started, diabetes has started, has to keep the sugar levels well under control, especially if he's undergoing any kind of procedure, and cataract is one of them, one of the most significant ones, because uh, if in case he's not maintaining a stable normal sugar level, he's at a threat to catch infections at a higher, he's at a higher stake to catch an infection. And his post operative period also will be a little, troublesome, like he might get a recurrent swelling. Also, if his creat levels are high, or if his eye condition pre cataract had been with cataract along with retinopathy, so he will be at a higher risk to develop diabetic macular edema, which is an advanced form of diabetic disease, where the central vision gets hampered, because in nowadays recent advances we do phacoemulsification to extract the cataract out of the eye. We use phaco energy, and this energy is normal for a normal retina, but for a vulnerable retina of a patient who already has a pre-existing retinopathy, this energy can in some cases cause swelling of the central part of the retina, which will cause immediate drop in vision. Of course, it is curable and it is completely treatable. But then the trauma that the patient undergoes, that, oh, my vision is not clear. Oh, doctor, what has happened? Has the surgery failed? Why the vision is now becoming bad again? So after cataract surgery, patient has to maintain very good sugar levels and hygiene, avoid to catch any kind of urine infection, blood infections, and at the same time keep checkups, because suddenly out of nowhere he will feel that, okay, they are lost for 2 years, 3 years. They feel, "Arey, cataract to ho gaya, so now my vision will never be blur." Now when they suddenly vision is blur after few years, they correlated that, why the cataract is out. So they don't know that the diabetes in the body will remain even if the cataract is out. The retinopathy is already, they are at a danger and a threat to get retinopathy whether they have cataract or not. So there is this myth, कि cataract हो गया तो मेरे diabetes का असर मेरे पर्दे पे नहीं आएगा. No, it's not like that. In spite, I tell all my patients who undergo cataract who are diabetic that, see, I have removed the cataract, but now if your vision falls, it means that you are at a higher danger than you were with cataract, because your retina will get involved. So come for checkups for 6 months, and these patients need to be mindful of it, that yes, in spite of getting the cataract removed, we should keep continuous checkup for the retina, because the blood flow will continuously keep giving sugar to the retina and spoiling the blood vessels of the retina. So not to wait for the last stage of bleeding in the retina or central part of the retina getting swollen and his vision dropping, not to wait for so much. These patients have to maintain complete infection control, especially the immediate 3 months of just a moment, huh?
No problem. Right. So I think
Yeah, so that's it. That's
that's
it. They have to maintain better hygiene and better sugar control.
right. Right. No, thank you so much for. I think that's very eye-opening, to say the least. Dr. Tushar, I have two quick questions for you. Uh, Very commonly asked, one of the most researched questions. Uh, Number one, we were talking briefly about foods. Dr. Kavita mentioned, not alarming, but definitely eye-opening things for us. Yeah, on that note, what are the foods that somebody with diabetes can eat when they have sudden hunger pangs? Right. That's one very well-researched question that a lot of people ask. That's one. Second is hypertension, heart issues, and thyroid. इससे डायबिटीज का क्या रिलेशन है और कितने हद तक रिलेशन है, राइट? ओवर टू यू सर. You're on mute, sir.
Yeah. So coming to the first question, the foods that one has to be aware of when they are having hunger pangs. One is they have to have a high protein food, uh, foods which are having high fat, and as well as some amount of calories should also be included. So high protein foods, fruits, vegetables, basically mainly legumes and pulses. They have to be consumed. High protein diet, berries, mm, uh, nuts. Nuts have to be included. Nuts are also good in proteins, also fats. So nuts like walnut, hazelnut, pistas. So these are the foods that give them instant energy, proteins, and a high fiber diet as well. So these foods have to be included uh, while talking about diabetes and when they are having sudden hunger pangs. Now, the relation of hypertension, heart disease, and thyroid. So, it is a very significant relation between primarily when we are talking about blood pressure and heart disease, because this is basically a lifestyle disease. And when it comes to blood pressure does not become a risk for the patient to have diabetes, but in patients with diabetes, they are at risk of having high blood pressure. because of basically the viscosity of the blood and everything. So high blood pressure again becomes a risk factor. Diabetes becomes a risk factor for heart disease. So both are risk factors for heart disease. Along with that, I would also add that obesity is also one of the uh, epidemics that we can call, and it is a risk factor for heart disease as well. So primarily, patients are worried about the heart. Whenever a patient comes for chest pain, they are worried about the heart. They are not worried about acidity or anything else.
In
So
fact, I have a ton of questions for obesity alone because I don't think
true.
any number of
Uh,
questions can cover, obesity
Yeah, the
and
obesity itself will become another topic for
topic.
discussion when yeah. So
Absolutely,
that's why I wanted to add obesity into this because obesity has not been covered and it is very
it's a
important
Pandora's
for
box.
diabetics. Correct.
Yes,
It is very important for diabetics to know that obesity is very important while because it becomes a factor for insulin resistance. And
right,
if you are obese, it is very difficult for you to control your diabetes. So let me just say
right,
that while control of diabetes is important, 50% I would say control should be done by the medicines, but be it oral medicines, insulin, and 50% of the times I usually ask my patients to control their weight as well as their lifestyle including diet and exercise. So
right.
mainly they have to concentrate in bringing down their blood sugar to some baseline by using these strategies of diet and exercise.
Perfect. Thank you.
So
Thank you for
basically,
explaining.
reducing the weight. If they are overweight, they have to bring down your weight to bring down the insulin resistance and control of diabetes.
Right. Right. So we spoke about hypertension, we spoke about cardiac issues, we spoke about thyroid issues, we spoke about possible, obesity and morbid obesity related, issues, and in fact, like we discussed that weight loss is the most burning and raging question across the country. Uh, Everybody who is not fat is also researching on that, and people who are fat, are always researching on that. So I think that brings me to my next question, and probably the most hot topic question in the panel, Dr. Kiran, if you can help us with this. uh, अगर uncontrolled diabetes
So,
लीड्स टू मॉर्बिड ओबिसिटी, राइट, और मान लीजिए पर्सन जो है वो बहुत ही ओवरवेट है, ही हैज अ बीएमआई ऑफ 8 9 और वर्स, what are the precautions a surgeon has to take if the person is going to undergo a bariatric surgery? From a general surgeon's lens, what do you sort of have to say about that?
So basically, when we are talking about the obesity, overweight and obesity. So when you are talking about the obesity where BMI is very high, so we might be along with obesity, along with the diabetes, patient might have sleep apnea, hypertension, and something like symptoms. So that time it will be just not to reduce the fat from the body. It becomes the surgery which will take care of metabolic syndrome what which is the patient has got because of the obesity. So in these conditions what we suggest, we primarily we give the guidelines to the patient, so how he has to behave if he wants to plan. First, the most important thing is the lifestyle. Second, medications. And third, exercise. Along with that, if he is ready to work out the things, but overweight people it can be easily managed, but very high obese patient, it is exercise is quite difficult for them. So but uh, planning with a dietitian to make a diet control and all these things, if he is following that, and also the social psychological behavioral changes. So he has to know that whenever we are going, there is a failure of medication along with the lifestyle and exercise, then he has to go to the surgical interventions. So there are surgical interventions, we are going for the temporary part and the permanent thing. So temporary surgeries, which are that the for the time being, the patient will take less amount of the food and he can utilize his fat for the metabolism or his body energy utilization. And then after, whenever he come to the normal or whatever the required weight, so we can reposition the means we can remove that whatever the balloon or something temporary techniques we have used. But if it is not possible and the patient is having a metabolic symptoms like obesity or along with the diabetes or hypertension and all these things, so you might go for the surgical intervention. In that surgical intervention, the principle is that, so any of the principle for the obesity management is either we are going for the diet control and everything. We want to utilize patient's own fat for the energy metabolism, and that will help him to reduce the weight. So same way we will go. If it is not possible with the diet and all exercise, then we will go for the surgical intervention as a sleeve gastrectomy. Means we are reducing the volume of the stomach. Because of reducing the volume of the stomach, which will support, now suppose the stomach volume is about 1 liter or 1.5 liter as a maximum, but we will reduce it as to the 125 or 130 gram of the food particles, so food whatever they utilize. So this is very drastic change, which will not be acceptable by most of the people. So that's why the diet control and everything has to be taught to the patient, given the social behavior. And then after that, this is the one procedure I'm talking about, the sleeve gastrectomy. But if the patient having metabolic syndromes along with that, means like hypertension, thyroid, sleep apnea, so we might go for the bypass also. So utilization of bilirubin and all this will be reduced. Means we are reducing the stomach, along with that distal small bowel will be attached to the stomach, so that the absorption rate of the fat and everything will be reduced. So these are the principles. Means one, decrease the food. Second, decrease the absorption of the fatty food will be the principles to manage the surgical way for the obesity. But this see surgery, even if you are saying it is a permanent surgery, it doesn't mean that like any other surgery. It doesn't mean that you are the patient, a very high obese patient, gone through the surgery and his problem is solved. It's not like that. So same thing, he has to continue that diet control in his whole life, so that whatever the fat is utilized for the metabolism, along with that he will not get the excess food. Sometimes there is a psychology of the patient, because he or she think कि my volume was means about this much, and now it is reduced within a 2 3 months, about 8 to 10 kilo I have lost, so I might feel weakness and everything. And they miss, and doctor has told me ki I have to go for 120 130 gram of food. So I will, they might be repeatedly eating that way. And as a stomach has a capacity to regrow to the normal size. So that's why the psychological thing is also more important as along with the surgery.
Right, right. No, perfectly explained. I think uh, if one has to tackle obesity, it has to be tackled in a holistic way, in a comprehensive way, and every single facet has to be looked upon: psychological, mental, lifestyle therapies, and of course, there is surgery at bay always. Right. So. Another very burning question that everybody is asking or researching today, Dr. Kavita, you might be knowing this, that Wegovy, Monjaro, Ozempic, these are the current fads in terms of weight loss drugs. They work on GLP-1. They work on hormone-induced ways to sort of curb your satiety. Right? What is your take on that? And how safe is it? It is FDA approved. So how safe is it? Or do you sort of suggest it to your patients?
Yeah, definitely. So I do prescribe them to my patients, and they're very safe. But patient selection is necessary in these patients, because you have to check all their parameters first before prescribing it, or else a patient is going to land up with issues. But GLP-1s, GIPs, twin cretins, they're all very safe to take.
Right. And are they identical in nature, or they are different composites?
So yeah,
which one
GLP-1
works more
receptor.
for which one works more for which type of patients? Do you want to sort of throw some light on that?
No, nothing like that. GLP-1 receptor agonists are different class of drugs. GLP-1 and GIP are very different class of drugs. That's a combination of incretins itself, but they act together, and they have different pathways for sure. But certain patients can tolerate, certain patients don't tolerate. So which is upon the patient and the doctor to discuss about it, to discuss the complications, to discuss what is happening, see whether they tolerate it or not, and then go forward. You cannot just simply increase the dose of that drug for any patient.
Right. So we have, unfortunately or fortunately, we have seen a lot of people self-administering them by seeing a lot of celebrities who are recently doing this.
Yeah,
I think one message to all
yeah.
is, please don't.
Do not do that.
It's
Do not do
yes,
that. You will end up
like
with severe complications, and there will be no one who can save you from it. So please, under supervision of a very experienced doctor, only take these drugs.
right. So thank you, Dr. Kavita. So as she mentioned, viewers, it is safe. However, it's very, uh, patient to patient oriented, and the dosage and everything has to be decided by the doctor. So that's sort of what we know about Mounjaro, Ozempic, Wegovy, and other things now that in use. Dr. Sanjay, very uh, prominent subject, very prominent topic, and there is a huge sort of research going on in this particular field. Uh, Erectile dysfunctioning and reproductive issues that are caused in uh, long-standing diabetes patients, right? How can patients approach these concerns? What treatment options are available today? Because as we all know, these are little sensitive topics. Not many people come out in the open and talk about it. But these are issues that people face. And in your practice, I'm sure you come across a lot of people who have this issue. So how do you sort of go about it, Dr. Sanjay?
So in diabetes patients, the main issues are erectile dysfunction, Peyronie's disease, and fertility problems. So erectile dysfunction is the commonest one. And regarding erectile dysfunction, I would rather say that whenever a young male comes with erectile dysfunction and who says that I was on a pre-diabetic level, now I have erectile dysfunction. So this means that patient's level of sugar have gone beyond control. He has developed vascular issues, among which the vessels to that supply blood to the penis are being blocked because of the increased sugar level, and then he has developed erectile dysfunction. Another thing to note here is those who develop erectile dysfunction before being diagnosed diabetes, or initially after diagnosing diabetes, then they have a higher chances of getting cardiac problems in future. So for erectile dysfunction, the diagnosis is patient comes to you by himself. They tell it was it was previously too hard, but now it is not getting too hard as compared to the previous one. So initially, apart from the lifestyle changes, sugar control and blood pressure control, patient has to be started on medicines. So oral medicines are nowadays available. So apart from Viagra, that was initially uh, came. So, but Viagra, because it has a lot of side effects, especially the cardiovascular. So the newer molecules are now there in the form of tadalafil, in the form of avenafil, that are available in India. So these drugs take care of erectile dysfunction in around 70 to 80% of the patients. Apart from that, those patients who do not improve on these medications, they can get injection therapy. So medicines are available that they can inject directly into their penis for complete and very good erection. Apart from that, those who are not willing for injection therapy, they can have vacuum erection devices where patient has to use mechanical pump that helps in achieving an erection. Even if these things fail, then patient will go for penile implants. Penile implants, they come in two forms: Indian and American. So Indians are semi-rigid because in India we get them easily at a low cost, and American is costly, but it is better because it comes with an on-demand erection. So these things can be used. And apart from this, there are few new therapies that are coming. One among these is the use of melanocortin receptor agonist. Though it has not come as directly as an allopathic medicine, but it has come as a nutraceutical by few companies. It helps in triggering erections without any sexual stimulation. So few patients may
Right.
help, but studies are going on over this. So and for Peyronie disease, patient can give uh, low shock wave therapy or laser therapy, which can benefit them. And in for Peyronie disease, finally, if it is hampering the sexual activity too much, then patient may go for a surgical intervention in the form of replacement of the patch of the Peyronie disease patch by a bovine graft or cells from the body, either rectus sheath or something else.
Right.
Same
Right.
that consists of same consistency. So these things help, and
Sure.
fertility issues are mainly because of the oligospermia. So these can be dealt with the hormonal therapies in consultation with the andrologist as well as with the female fertility specialist, because a male and female partners both are to be treated simultaneously.
Done. Yeah. No, thank you. I think that was elaborate enough, and I think a lot of people that clarifies a lot of people. Unfortunately, suffering through this, or who knows somebody who's going through this tough time. My last question, and then we sort of go over to everybody for a quick, larger message to everybody before we end it. And my last question, Dr. Kiran, uh, for patients with cancer and diabetes, right? Management often becomes very complex, as we know. How do you balance diabetes control with cancer treatment or surgical intervention, and what role does multidisciplinary care play here? If you
So
can
basically,
briefly
yeah.
explain that. Yeah. So
Yes, whenever we are talking about diabetes plus cancer surgeries, so what will happen? Cancer itself causes decreased immunity of a body for that patient, and along with that, diabetes. So there will be the the patient is more susceptible to the infection and everything. So that's why whenever we are planning for surgery, so most of the patients, they will led up in multidisciplinary program, because the diabetologist physician, they have to take care of the patient's systemic diabetes control. Second thing, because of the diabetes, we have repeated talk, so there is a vascular involvement, so atherosclerotic changes are more common with that. So which kind of cancer surgery, I mean, GI surgery or something like we are going for, so we have to take care of the vascularity of that areas, how to tackle with that. Third thing, dietitian. Then the we are whenever we are planning for surgery, most of the time cancer surgery, these are elective surgery, but only in colonic obstructions we are going for emergency surgery. So whenever we are planning for emergency surgery along with the diabetes, so we have to shift patient on from the oral hypoglycemic to the insulin, so get a proper control, and we have to get a good diabetic control before the surgery and post operative for the 4 5 days. That is more important because of decreased immunity and hyperglycemic level. So there are chances that wound infection is more. So that's why we have to take care of the multidisciplinary action prior to the going for the elective surgery, and even for the emergency surgery, it will minimum physician, dietitian, surgeon. So that has to be taken care of, and along with that, physician also, physiotherapy also come in picture.
Right. Thank you, doctor. So, I think we tried to cover almost every aspect of diabetes here. And like I had told in the beginning, because we have a wonderful, forum here, comprising surgeons, comprising, multidisciplinary, like Sir was saying, multidisciplinary people. So, I think this session was informative. We hope this session was informative for everybody. We tried to cover everything. Before we close this session, I would like to ask one single and quick question to all of you. What would you like to see change in people's habits so that they can enjoy healthier lives? Be quick, and we start with Dr. Nusrat. What is that one call to action for awareness that you would want to end with for everybody seeing this, this webinar?
As in, your query is for all the people
For
or only
everybody,
for
what's your message for everybody with diabetes or not? But how do you envision a healthy lifestyle for them when it comes to your sort of discipline, right? And I'll then
I,
go over the forum.
I truly believe that we all should be mindful of what we eat, have at least some amount of adequate, if not intense, at least some amount of physical activity, be it walking, exercising, anything, okay? And if we don't know, then take the proper advice from a dietitian, from an endocrinologist, or the concerned people. Third, please, in today's time, my advice to all and everybody is, please reduce screen time if possible, at least at home. I understand everybody has 8 to 10 hours of screen time work, but at home, at least try to avoid screen time from my side.
Perfect. Thank you so much. Dr. Tushar, over to you.
So the most important thing for all the patients is the patients have to go for an annual preventive health checkup, which is very important to diagnose not only diabetes, even for that matter, any other diseases that might be hidden inside. It should include ultrasonography as well. So ultrasonography is a very important tool to diagnose things. Secondly, one has to make sure that patients might go into hyperglycemia, high blood sugar, which is sometimes okay. Yes, their blood sugar has to come under control, but they should never get the symptoms of hypoglycemia, because if they get the symptoms of hypoglycemia, low blood sugar level, then it is the patients feel very scared of taking medicines and the second and going into hypoglycemia the second time. That's the reason why the patient should not ever go into hypoglycemia for the first time, because the second time it becomes very difficult for blood sugar control because of the resistance of the patients in taking these medicines. So that
Perfect.
is one point that needs to be taken care of.
Thank you, Dr. Tushar. In fact, both the points. In fact, the first point was you just hit the nail on the head. Uh, Instead of having reactive health checks, please have proactive and preventive health checks.
Preventive. Yeah.
I think that's one favor that you can do to yourself and your family. Stay on top of your health and get yourself checked every 6 months, or once a year at least if you're young. Uh, you will not be in for a shock or surprise, right? Dr. Kavita, your message, please.
Can you hear me?
Yes, ma'am.
Yeah. So, continuing from what Dr. Tushar is saying, hypoglycemia is very scary. Okay. I mean, if we have sugar of 40, there's going to be palpitations, and they're never going to want to take medicines again. So, counseling is necessary. The second thing I want to say is International Diabetes Federation is focusing on diabetes in workplace. So, people who live with diabetes need to be supported by people who don't live with diabetes. So educating those people who don't have diabetes is also very necessary. And at workplace, supporting these people where they take insulin is not a shame. And taking insulin is not shameful. You don't have to be ashamed. It is very normal. So normalizing diabetes in the workplace, that is what I want to focus on, and that wherever support is needed, support is given. That's
Perfect. Thanks for
that's.
bringing out that angle. I think nobody could have said it better. Diabetes at workplace. Please ensure that you,
Hmm.
if you are not diabetic today, good, stay that
Yes.
way and help the others who are. A help is all
Yes.
that they need. Dr.
Yeah,
Sanjay,
and
your
the
thoughts?
other,
Yeah,
the
sorry.
the
Yes.
other small point I want to say is mental health. So these
Yeah.
diabetic patients also suffer from depression, anxiety. So that is also where the other part of support comes in for these patients.
Yeah, they are easily susceptible to anxiety, depression, and they keep falling low. So whatever
Hmm.
help you can do from your side, please do it. Dr. Sanjay, over to you.
So as Dr. Kavita said, awareness, and not just to the patient, to the people who are in and around the diabetic patient. So for me, I should say that it's just one life. So we should not take this thing as a disease. Means all patients should not take it as a disease. In fact, the family members and the friends should support and consider this as a new task, like everybody doing his or her job. They are managing most of the things. So this is one more task that each and everybody is getting. And if they are managing this task very happily, so this disease can go on very easily and there will not be any burden on the patient. And like other tasks, it will be solved in on time and can be managed on time.
Perfect. Perfect. Thank you. Dr. Kiran, your concluding remarks, please.
As a surgeon, we are concluding on 2 points. One is obesity, and second is the diabetic foot ulcer. So, for the obesity, I am saying key patient has to go for the good, healthy lifestyle and diet. As there are so many modes are available for the intermittent diet and 1 hour eating for the to avoid the resistance of insulin. So that is the one purpose for the obesity. Second thing, the most important, the 40% of the diabetic patient in their life span, they are going for the diabetic foot ulcers. So the most important thing is they have to be aware of their food sensation, their self-examination of the foot and a diabetic patient, or they have to regularly follow up with their physician or surgeon. Second thing, offloading and the wearing of shoes, diabetic shoes or sandals, which will be have a hard part on the outer side and the soft part inside. So it will take care of the pressure points, and there will be no neurogenic ulcers and everything will happen. So the most important thing, the take home is the last point is that is a lifestyle changes, diet control, and regular follow up with their physician or the surgeon.
Perfect. Thank you so much. 10,000 steps or not, but please ensure that you walk regularly. Calorie count or not, but ensure that you eat not to your fullest, but keep a little empty. And, like the eminent people in the panel just said, that ensure that you're on top of your health by regular monitoring and preventive health checks. I think we are not saying that this will help you, completely, but at least it will help you prevent uh, at the optimum level, in order to fight it or in order to ensure that you prevent it. Thank you so much. So, concluding this with an ending note, this was truly a very powerful and an eye opening session. On behalf of the entire team of Apollo Spectra Hospitals, I would like to extend my sincere gratitude and appreciation to this esteemed panel of specialists in the field of medicine. The discussion on today's subject brought light to quite a lot of diverse insights ranging from lifestyle changes, nutrition, preventive care, cancer management, obesity management, hyperthyroid, glucose management, etc. And we are very thankful to all those who attended, who made time from their busy schedule and attended this webinar despite your multiple commitments. Uh, at Apollo Spectra, as we all know, we believe that the future of medicine is not treatment based protocols. It is rather preventive healthcare. In the coming years, we envision that almost every citizen globally, or in India, will work towards sustaining good health instead of searching for cures. This panel of experts and the discussion today was one small step or initiative towards making this future a reality for all of us. We are so grateful to have you all present virtually. Thank you so much. Have a lovely day. Stay diabetes free and happy World Diabetes Day once again. Thank you all. Namaste.
Thank you. Thank you.
Thank you very
Thank
much.